So for now, we will be moving on to the second session of today's webinar. Speaker for this session is Dr. Ugonna Nwigwe. She's a healthcare transformation leader, clinician, and entrepreneur with over 2 decades of experience across Nigeria's public and private health sectors. She serves as the Deputy Director at the National Health Insurance Authority, where she leads regulatory standards, governance, and compliance, shaping the frameworks that govern health insurance operations and accountability across Nigeria. She's also the founder and creative head of the iPlace Eye Clinic and Optical Boutique in Abuja, built while in full-time public service. She holds a Doctor of Optometry, an MSc in Health Promotion and Public Health from Brunel University, London, and PMP certification, and is a PhD candidate in Health System Management. A Mandela Washington Fellow, the WIM Board Fellow, and member of the Chartered Institute of Directors. She speaks and writes on public financing, regulation, AI in health, and women's leadership. She'll be speaking today on how public health decisions are made. Dr. Gunnar, the floor is yours, ma'am.
Thank you so much. Good evening, everyone. I'm very delighted to be here today. Let me just quickly make an attempt to share my slide. Okay, so thank you so much. I'm very happy to be here, like I said earlier. And I think I have 20 minutes, and I'm very time conscious, so I'll just go right into it, right? So I want to start with something that took me so many years to understand, even as somebody who has been inside the system for over a decade, like my bio said. Over time, I realized that every decision that shapes health in Africa is made in a room. You know, the diseases that get funded, whose data is important in the grand scheme of things, whether your local clinic in Bayelsa or Owerri or Kampala is going to get their medicines for the next year. There's someone or people somewhere who have sat in a room and made that decision. And for the longest time, for me, those rooms felt really far away, even to me, who has been on this journey for a really long time. As a clinician who has now become a regulator, entrepreneur, in fact, I've touched on all spaces. I'm now in academia, I'm lecturing as well. So I can imagine how far off it also feels for you young professionals who are, getting into the space or have been in the space for a much shorter period of time. So one thing I want you to know tonight is that these rooms are occupied by people like you and I. We need to know who sits in them, how the monies move around, how the votes move, and how somebody at your own stage in your professional journey can begin to get into this room. Because honestly speaking, in Africa's future in the global health depends on whether people like you learn how these machineries work, the architecture around them, or you leave it to others. So let's put the whole system in one slide, right? You can see on this slide, we have what I'll consider 3 floors. At the very top, you have the WHO, like we all know, the World Health Organization, which is run by the World Health Assembly. And here, every country, including all 50+ African states, they have 1 seat each, which means each country, 1 seat, 1 vote. WHO is where the standards are set, but it doesn't hold the money. The money sits in the middle layer, you can see there, where we have the global health initiatives. The 3 big ones are the Global Fund for AIDS, tuberculosis, and malaria. We have the Gavi for the vaccines, and then we have the Global Financing Facility, GFF, for women's and children's health. So around them, we also have the World Bank and the donor governments and the big philanthropies. You hear things like, people like Bill Gates running certain programs or funding certain programs. This is where they all come in. And then the last layer that is the closest to home, the African Union, you have the African CDC, and of course the national governments and the regulators. The bottom layer is where I work, the National Health Insurance Authority. So it's important for us to put all of these things in perspective and hold onto these layers as we proceed so that we can understand where we are going to from here. Because everything above the first layer, WHO, and the second layer, the global funds, the Gavi, everything only matters if it gets to the last layer, which is African Union, institutions, the governments, and organizations that actually implement everything else that happens before it. Now, one of the most useful things I can say to you tonight is that on paper, right, global health looks very democratic. You hear things like 1 country, 1 vote at the assembly, and with Africa having like over 50 votes, right, most of the important decisions are actually not made by the Africans that have a significant chunk of the votes. And they aren't even made at the assembly. Any decision that concerns money isn't particularly made at the assembly. That is where you have the standards, the policies, and much like having a town hall executive, right? You have the ESCO. But then when it comes to things like the launching, people that pledge the most are the ones that determine how the money goes. So these decisions around funding is made on the boards of the funders. Who are the people on the board? And the influence follows 3 things. Who is the person that gives the money? Who holds those seats, and who pledges at what we call the replenishment. The replenishment is like a fundraising round where donors refill their account. The global health runs in cycles, right? So say every 3 years, the countries and the big players come together at what we call the replenishment, and they make their pledges, and people are saying what they are going to contribute to the funding or the pool that will then fund the next cycle. So the scale is normally huge. So these 3 institutions have been asking donors for close to $28 billion in the recent round. So you imagine that when somebody writes a check that size, they will have to shape the priorities automatically. So even though African countries have a seat too, they fight really hard in them. but obviously the tilt will be very evident because there's a saying that says who plays the pie detects the tune. I'm not sure if that's how it goes, but something along those lines. So when you say that the priorities don't really match our own realities in Africa, it's not really a mystery, right? It's the architecture of how the whole system was designed. But the good news is that any architecture that has been designed can also be redesigned. Now let's look at this number. I always remember these numbers. Hopefully it shocks you enough for you to take a step, to move the needle, right? There's 25, there's 3, and there's 1. So Africa carries about a quarter of the world's disease burden. It just means that if there's 100 diseases, 25 of them are in Africa. So you divide the world disease burden into 4. One chunk goes to Africa. And with that statistics, you still realize that only about 3% of the world's health workers are serving the 25% of the disease burden. And even more so, less than 1% of the world's health money comes to Africa. So imagine having 25% of the disease burden, about 3% only of the health workforce, and then less than 1% of the finances. So, and it's projected that by 2030, our region will be short more than 6 million health workers, whereas we are the youngest continent on the earth. And by 2050, it's also projected that 500 million people today will be in Africa, and then that the median age of Africans will be 19. So there's going to be about 2.5 billion people in Africa by 2050. And people who are going to close this gap are already born. This is not a case of where we say the beautiful ones are yet to be born. The people who are going to close this gap and make impact and shift these things are right here on this call with us. Around 2001, our own head of states, African heads of states, promised like 15% of the national budget would go to health. And we are 25 years later from that promise. Most countries, Nigeria included, still haven't even met up to half of that amount. So the gap is not just one of those things we see on paper. It's right here with all of us. We can see that promises have been made, but they really haven't been met. So for 20 years, we've lived with these, uncomfortable arrangements. Our budgets are underfunded. Donor agencies feel part of that gap. I'm sure a lot of you have sat in several conferences where all this big English have been spoken, so much grammar. In fact, the last one we had at the Hilton, I was just a bit frustrated. Like, how long do we have to sit and talk about the same things and make no progress whatsoever? So we've argued about whether this funding from donor agencies is sustainable, whether we can continue to do it, whether we have to look inwards. And then in 2025, that argument ended abruptly. How did it end? The biggest donor country wound down its aid agency and started leaving WHO. So aid for health dropped sharply across several donors at once. It was unprecedented, it was unplanned. Programs that the whole national disease responses relied on suddenly weren't sure of their future. And these heat systems are already struggling, even before the shock. In more than 70% of the countries, ordinary people were finding it really hard to pay for care without hardship. Now people may disagree with the political decisions, but we are not really here to discuss politics. The one lesson that we should take away from this is that any health system that depends on another country's annual budget was never really sovereign. It wasn't ours in the first place. So it's not like the old model at some point we agreed that, okay, this is undesirable. It just became unavailable, which is why the next slide we're going to go into is so important for us. So I'm sure a lot of us have heard about the Lusaka Agenda. This is a framework that I want us to leave here with tonight. After today, when somebody here hears about Lusaka Agenda, you actually know what it is. So in 2022, Kenya and Norway, Kenya, an African country, and then Norway, a donor country, together asked one very difficult question that I'm sure has been on the mind of so many people. After 20 years of these global funds, the Gavi and the GFF, does this model still fit? So 14 months of dialogues later, the answer landed in Lusaka, Zambia. It was launched on the 12th of December 2023. It asked the funders to make 5 shifts. These 5 shifts, as you can see on the slides, they asked that the funders should invest more in primary health care, right, as opposed to funding individual health priorities, like funding the cholera. You talk about polio, you talk about malaria. Let's fund the health system that carries all of these things, right? And it also talked about domestic financing, so that whatever monies the donor agencies bring will just be more catalytic. Help us to start, but let us build a system strong enough that eventually we don't need the funding from you. That is at the heart of this Lusaka Agenda. And then he also talked about working jointly on equity, so that the care somebody receives in Nasarawa is just as good as the one somebody receives in Aso Rock. And also coherence. Let's coordinate, because several uncoordinated funders can exhaust one small Ministry of Health. You go to a health facility, there's one that Bill Gates is funding. There's another one that Gavi is funding. There's another one that Clinton Health Initiative. Like, there's just so much going on, and everybody doesn't really know. Everybody's a little confused. So let's coordinate amongst each other and have some semblance of synergy and coherence. And then he also talked about the last layer is regional manufacturing, so that Africa can make more of what Africa uses. I mean, these things are not supposed to be rocket science, right? They are common sense. But, sometimes you just really have to spell these things out, agree on them, and take active steps towards accomplishing them, which is what the Lusaka Agenda framework is all about. So, the thing about frameworks, from my experience and from the work I do, I work in the regulatory standards and governance for National Health Insurance Authority. So my role is to design frameworks, templates, policies, and stuff like that. A framework on paper is just paper. What makes a difference is what you do with that framework. So for this Lusaka Agenda and the Lusaka Agenda framework, what Africa does with it is what makes a difference. So in February 2024, I think barely 2 months after that launch, our heads of state now endorsed it as a formal assembly decision. By the end of that year, the Continental Secretariat had been set up in Africa CDC to track the implementation. And through 2025, that Secretariat has now finalized a monitoring framework and a continental scorecard so that progress can be reported to the heads of states rather than filed in the drawer like all the other frameworks we've had over a period of time. And late last year, the G20 leaders referenced the Lusaka Agenda in their declaration. So look at the sequence. A framework about reforming donor institutions is now anchored, tracked, and scored by African institutions, and it has entered the language of the world's biggest economies. So these frameworks are where negotiating powers get scored. Any country that arrives a board meeting with an agreed continental position and a scorecard negotiates differently for somebody that's just coming to make demands, right? So we are hopeful that your generation would not be the ones, to continue to negotiate global health and Africa's health system with speeches. You will do that with frameworks and the patience to enforce them, because those are completely different stories. So let's now bring this home, and I'm speaking from a very personal perspective, right? In my own experience as a clinician, a regulator, everything we discussed tonight, the boards, the billions, the framework has to pass through one gate before it reaches the patient. Ultimately, everything we are doing here is how we can improve health outcomes. How will the person in faraway Sokoto access the same quality and have access to healthcare just the way somebody in Abuja Municipal does? Right? So a national institution with the power to enforce it is actually very, very important in a conversation like this. For Nigeria, one of those institutions is the one I work, NHIA, National Health Insurance Authority, and through the Act of 2022 has made health insurance mandatory and turned an otherwise scheme. It used to be National Health Insurance Scheme, now National Health Insurance Authority. So what the Act has done is to turn that scheme into a regulator. And the one thing the books wouldn't tell you is that passing the law is the easier part of the conversation. Making it or implementing it is where the work is. It means accrediting health maintenance organizations, HMOs, again and again, setting capital rules so that schemes can actually pay claims to the healthcare providers, making sure that the enrollee data is monitored, uploaded, and is quality in a way that can actually inform decisions, right? So that the coverage is not just on paper, but it's actually just as claimed. And we follow up with institutions that also do not comply with these things. So that's the last mile of the global health. And, it gets worked one secular, one decision at a time. So when you write your own recommendation tonight, like a tax that you will have later on, remember this: any recommendation without an owner, and by that I mean an institution who is going to implement it, carry it, enforce it, regulate it, report it, is just a mere wish. So now to the very interesting question: who gets into these rooms? It might interest you to know that it's typically not the loudest in the room that gets into this room. It's the most fluent ones. I've watched committees, delegations being put together for years, and the pattern is very consistent. The people who get picked are the ones that understand the machinery of the place. The politics, the machinery, the language. They know terms like replenishment, what a board constituency is, what Lusaka Agenda actually commits anyone to, right? And here's one good news that, it should be obvious. Fluency is learnable. You don't need connections. You don't need any money you haven't earned. Everything I've told you tonight is public. Documents are free. Most people never do the reading. There's a saying that goes, an embarrassing one. It says that if you want to hide something from an African person, you put it in writing because we don't read. So you now have a few minutes of head start on most of your peers. And the next 2 slides, I'm going to turn that into an implementable plan. Now, let's look at how to get into these rooms. My recommendation would always be to start in the nearest room, not the farthest one. I think everybody wants to be in Geneva. We cannot all be in Geneva, unfortunately. I wanted to be in Geneva as well, but my trajectory changed and I embraced it and I'm happier for it. So I want us to know that we cannot all be in Geneva, right? So ministries run consultations, technical working groups all the time, and they're always short of capable hands. So one step you can take is to write to one of the secretaries and ask how junior contributors can get involved. That's the first door. And these doors are not in any particular order. Like I said, assess the one that is nearest to you. The second door here is the civil society seats. The big funders always reserve a real governance seat for civil society, and platforms exist to organize those voices. You can join the Universal Health Coverage 2030 mechanism or African Constituency Bureau mailing list and read one set of board papers, right? Just read, educate yourself, be able to speak the language. Every community, every industry, every sector has a language. If you're not speaking the language, you will come across like an outsider. And the only way you can do this is to read and engage in those communities and see how things are done, right? Another way is through fellowships. Programs like the ones I've been to, Mandela Washington Fellowship is just one of them. I've been to several, but I'm just highlighting this one because, I've been through it and it really does change your trajectory if you apply it correctly. So look for that fellowship, check for the next deadline, start your essay this month, and don't wait for the week that the essay is due for you to begin to apply for those things. The 4th door is my favorite, absolute favorite, writing. And I'm sure that's the one everybody likes to avoid. Every policy room I've sat in runs on documents, the briefing notes, the position papers, the reports. Someone has to write them. And the person who writes the documents shapes the decisions more than the person who is just attending the event. So it's one door you can open completely on your own. You don't need any influence. So pick one issue in your country's health governance. Write about 800 words on it. I mean, there's so many writing tools now. There's so many tools you just put context and ensure that your evidence-based writing is correct, your data is correct. Publish it where your professional communities will see it. Do it monthly and do it within a year where people can find you, right? For me, one of my favorite ways to write is LinkedIn. LinkedIn is democratized. Nobody's gatekeeping it. You can't do you understand? Nobody's gatekeeping LinkedIn. So I have my bosses there, but I ensure that everything I write doesn't bear any institutional risk. So it's a place where everybody can just express themselves and you can show your range of knowledge. When you show your range of knowledge, you're not put in a box, right? If I had introduced myself as an optometrist, maybe you would have assumed that I have nothing interesting to add to this conversation, right? But perhaps you have seen my profile, you've seen the ways I engage and topics I touch on. So those places like that are places you can show your depth, wealth of knowledge, and your range. And also being findable is, how this invitation starts. Your professional association is another place, pharmacy, nursing, medicine, public health, optometry, committee elections, budget negotiations with government. Every skill a global board runs on gets practice in a smaller scale. Just look for what I call the lower stake events and make yourself available there. Join one committee this quarter, volunteer for a task nobody wants to do. And like I said, it's usually the writing. And so in all of that, there's no point to summarize everything I've said because I'm sure you were listening. So let me just set you up for what is coming next. When next PHIGA, if that's how it's pronounced, PHIGA, asks you to make one recommendation on African health governance. One thing that makes most recommendations fail is because they're just wishes. People write things like health systems should be prioritized. That's just a vibe. You haven't said anything. It's not a recommendation, right? So I've written one that you can copy from. For instance, the Federal Ministry of Health should publish quarterly progress against the Lusaka Agenda Continental Scorecard beginning Q1 2027, measured by publication on its website within 30 days of each quarter's end. You see how that captures everything? You name the date, name the measure, name the institution. That's an example on screen, and you are allowed to agree or disagree with it. The point is that it's specific enough for anybody to even argue with. People can begin to say, do you think you can actually accomplish this but in 30 days? There's something to debate. There's something to argue, right? But if you just say things like health system should be prioritized, there's no conversation to be had, right? So let me end this where I started by saying that Africa's seat at the table was never going to be given. There's something our current president said. I'm not sure where and when, but I think he said power is not given. Power is the way he put it, which is true. Nobody hands over privilege, right? You have to go and get it for yourself. It's built framework by framework, institution by institution, and the people who will build and staff those institutions aren't just abstract to me or you. They are right here on this call with us. So please do well to go on and be fluent. Thank you very much.
Thank you very, very much, man. That was a very, very insightful presentation. I believe everybody else who has been on this meeting, on this call, agrees with me on that. So we're going to be going to the question and answer session now. Currently, I think we had the question in the chat box before. It's not here anymore. But nonetheless, we'll go over the questions that we had. Similar to the first question we're going to ask is similar to what we asked the first speaker. Regarding the argument about health decisions affecting Africa being made in Africa. So relating to your topic now, the question is that rather than those decisions being shaped by international donors and global institutions, from where you sit, is the global health system actually moving in that direction, or is it all just talk? So the conversation about African health decisions being made in Africa, is it all just talk, or is the global health system actually moving in that direction? Is it something we should actually take seriously, or is there a lot more work before we can even start that conversation?
So before we talk about whether or not to take it seriously, I'm not sure that we have that luxury of choice, for the want of a better word, right? Because people are pulling their resources, and it's only rational that we go back to the drawing board, which is really what the Lusaka Agenda talks about. Whether the Lusaka Agenda would then become a reality, or and whether the extra step that has been taken beyond the framework to go ahead to talk about handing it over to institutions like the African Union and developing a scorecard and things like that, which is the first time we are going that extra mile on issues like this. That is where the issue lies. Hopefully, these extra steps that have been taken towards making this a reality would actually make it a reality. So I'm very hopeful. I'm very, very hopeful. And with the way universal health coverage is going in Nigeria now, it's become mandatory, and the numbers are rising. I think we're at about 21 million Nigerians are currently enrolled, and the numbers are still going up. And the health systems is just being energized. We're having a really good time in the health systems in the Nigerian health system space now. A lot of programs are ongoing, so I'm very hopeful. I think we should take it seriously and find ways we can connect to this reforms that are going on currently, especially with the current Minister for Health, who had been in Gavi and several other global health organizations, knows how these things work, is able to attract certain things, privileges to us. So I think it's a good time to be part of the conversation, and I'm very hopeful.
All right, thank you very much, ma. So we have a question in the chat board, question from Adeandra Akintade. It says, in order not to get overwhelmed by the flood of information out there, how would you advise we begin to read? I mean, there are a lot of problems in society, so knowing what level to start seeking information is quite crucial. So that's his question. Basically, he's asking, in order not to get overwhelmed, where would you advise to begin to read to up our knowledge in terms of global health as a whole, in terms of decision making across Africa and the world at large?
So the first question I'd like to ask the person who has asked the question is, what is your interest? Global health, public health is very vast. Early in your professional life, I believe you begin to narrow down on what your interest is. It could be what you're passionate about. It may not be. It may be what you're good at. It may be what you have leverage. So if you can narrow it down to either your interest, your passion, your leverage, or the nearest door to you, that can help you to even know where to start. And, in a generation where we have a lot of artificial intelligence, I don't know, I wish I went to school in this time because everything is just so easy. You can just write what prompt, just what are the top 10 global health challenges? Which ones affect Africa the most? Where are the gaps? Considering my background, how do you think I can leverage my intellect, my knowledge, my wealth of experience, or otherwise? How can I apply it? It's just, I think that the issue I have, let me speak from a personal perspective, is that 24 hours is not enough. But if it's where to start from or what to read, there's always a way to funnel it down to one or two things, and then you can start from there,
All right, thank you very much, man. So another question that we have is that COVID-19 showed us very clearly that not every country, especially in Africa, has an equal seat at the table when global health decisions are being made. Now, do you think that things genuinely changed since then, or are we still in the same system coming from 2019, 2020 to 2026, which we currently are in?
Can you rephrase the question so that I can understand it well?
Okay, so COVID-19, the year of COVID-19, 2019/2020, it showed us very clearly that not every country, especially in Africa, has an equal seat at the table, because when it came to decision making in terms of how to manage the disease, some of the implementations were not favorable to the African continent. Now, between then and now, do you genuinely think that things have changed in terms of our standing in the global health community, or are we still in that same system?
So, if the architecture has not changed, then things clearly cannot change. The only way things can change again is if we take this Lusaka Agenda seriously and begin to wean ourselves off dependency. Because I don't think that any architecture in WHO, WHA, Global Fund, Gavi has changed. Is it still the same? The people that are voting and making the standards and policies, the people that are deciding where the money goes at the replenishment, and the institutions that you hand it over to, nothing has changed in that architecture. If nothing has changed, if any such issues arise, the people that are the bigger funders will still be the decision makers. So the only way is for us to be self-sufficient, which is what that Lusaka Agenda is promising. So we've taken a step in the right direction.
Thank you so much, Dr. Ugonna. Thank you so much for the very insightful presentation. It was really, really, really insightful. Personally, I learned a couple of things, and then it actually also made me wear my thinking cap and start to interrogate, the current architecture we have. And of course, health financing will always be a top issue when it comes to African healthcare landscape. So thank you very much. I wouldn't know if any other person has any question before we end today's conversation.
Okay, so we have one question here. From the questions we took before the meeting even started, reaching out to our participants. Somebody asked that, global health governance, it can sound very technical. Even Dr. Buddha mentioned it about all of the big grammar and language being used. It can sound very technical from far away, and then, especially for a lot of young people. The person is asking, can we get like a real example, like a decision that affected Africa's health, and then break down how that decision actually got made and who had the power in that process? So basically, from all of what we know and all we've learned about global health decisions and all that, the person wants like a practical example of a health decision that affected Africa, the process, and then who exactly was involved.
So the very quick one that comes to mind is, of course, the pulling out of the US from WHO funding now. That's the most impactful so far that has affected Africa, and a lot of fundings that were gotten by several African countries funding several diseases and several programs. America should be the highest funders of WHO, if I'm not mistaken. So pulling out from WHO shook the whole system. I have a lot of friends that lost their jobs, and everything was unprecedented. So countries are no longer receiving funding for programs that were being funded. So that's the biggest hit so far I can think of. Of course, there will be several others, but I'll consider that one the biggest hit. That's the one that really shook the global health landscape, and especially Africa, because obviously we are dependent on global funds and donor agencies, which are technically controlled by the biggest spenders, of which US is at the top of the list.
Okay, to piggyback on that point that you made, it's actually the excuse or the reason why that the US government gave as to being why they pulled out of the WHO was that they were spending a whole lot more than every other country significantly, and then they were not getting, I say, to paraphrase now, the recognition, quote unquote. So do you think that was like a valid reason to pull out, being that other nations were not pulling their weight as well, or was it just an exercise of power?
So for me, like, I like to introspect in some of these conversations, because it's much like asking somebody who is giving you money, is it enough reason for you to stop giving me money? I don't know if you understand what I'm saying. There's no rule that says anybody should fund anybody out of their own magnanimity or power tussle, because when somebody is funding you holistically, that person also has some control. They decided to fund you for whatever reason, and they're now saying that, oh no, you're not getting their own, you're not doing your own side of the bargain. I don't really think the right person to ask would be if their reasons are logical. I would like to look within and ensure that I never put myself in that position again. And that is what I think Africa should do.
Exactly. That was my thoughts as well. But I just wanted to ask, because a lot of other people, it was a very huge debate in the public health space globally during that period that it happened. And I actually think your point is actually very, very valid. Very, very valid. Finally, because of time, we have to quickly run this up. There's a question here. Say, what role should health educators play in Africa's public health future? How can we move beyond perception of health educators as only classroom teachers to recognizing them as essential public health professionals involved in health promotion, disease prevention, and policy implementation?
So you're going to have to go into a major, advocacy for yourself in communities that are not gate kept. Again, LinkedIn, for instance. And one way you can do that is to identify one issue that you can begin to hammer on. Begin to ask them how far this Lusaka agenda we'll be talking about. Every day you remind them. Do you understand? And before you know it, you drive some traffic around a particular conversation. You go viral, the conversations begin to, happen, people are asking questions. You'll be surprised at the impact you'll make. So do not wait to have any, what will I call it now, very defined community that will now say, okay, health promoters, this is now our industry. No. One thing I always say to myself, if you're not giving a seat on the table, you create your own table. Because I work in public service, so I know the dynamics of that place. Is anybody going to be able to tell me not to speak on LinkedIn? No. Right? But if I go to the office, my boss has to speak before I speak, even if I have something more logical to say. That is just the way it is. So find a space that is democratized. Just ensure that everything you're saying is within the confines of, proper health education, evidence-based, and not just, there's nothing to be political about. I don't even get into political debates, whether this one, that's not my problem. Let's just stay on facts.
All right. Thank you very, 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 very much, man. That was, the whole session has been insightful, really, really insightful. So at this juncture, we have come to the end of this webinar, Africa at the Crossroads, Population Policy and the Future of Public Health in Africa.